Hello and welcome to our podcast. My name is James Pito and I'm Head of Public Programmes here at Wellcome Collection. This podcast was recorded at one of our packed lunch events, which give people the chance to meet a local scientist, to hear about their experiments and what they're investigating, but also to hear about what their daily life is like. So this is both science and the life of a scientist.
Hello and welcome to today's packed lunch, to all of you here at Wellcome Collection and to those listening in Podworld. I'm Michael Renier. I'm a science writer at the Wellcome Trust and associate editor of Mosaic, which publishes in-depth stories about the science of life every week at mosaicscience.com. But getting back to our packed lunch today, we're going to be talking about stress, which hopefully won't be too stressful for all of us, especially as I have the pleasure of speaking to our guest today. Carmine Pariante is Professor of Biological Psychiatry at King's College London. Welcome, Carmine.
Thank you.
It's great to have you here. Now, first of all, I have to ask you, what is biological psychiatry? How is that different to any other psychiatry?
So it is looking at how the brain works at biological levels. It's trying to understand how the brain cells interact either in a functional or dysfunctional way in the context of stress or mental health problems. And the broader terms also include changing, if you like, more in the body, so changing the hormones, in the function of the body organs that communicate with the brain. So it's really looking at, if you like, all of the aspects of the biology.
Okay, so thinking of it in terms of cells and molecules and how they're all interacting to create these states in our minds.
Changing, regulating behavior, emotional states.
Okay, great, super. So now you're going to tell us why stress can lead to us getting ill. I'm sure we all have an idea of what stress is and how we experience it in our lives. Is that the same sort of stress that you're talking about in your research? I mean, when you're thinking about stress from that sort of biological, perspective, is it the same kind of stress, or is there a particular kind of stress that you're thinking about?
From a qualitative point of view, it's the same concept. It's a feeling of mismatch between, if you like, your resources and the challenge that the environment, that you face in the environment. From a research and from a clinical point of view, we obviously tend to see the most extreme spectrum of stressful circumstances. So when, for example, either the stress is really objectively overloading situation of threat to physical health or of their own integrity, or people's integrity, and usually because these are also accompanied by mental health problems. Okay. Which could be transient, and it could be part of the normal reaction, but sometimes the people need help for that.
Okay, and so let's explore that connection between the stress that people feel and ill health, mental ill health that can be associated. I mean, how does stress lead to or contribute to illness in that way?
So there's always a variety of ways that you can look at it. I mean, I'm more interested in terms of the biological mechanism.
Sure.
How stress leads to first change in behavior, and then sometimes behavior that may be not functional in the society today. It brings suffering or difficulties in the environment, in your daily life.
Okay.
Now, if you think about stress, biologically, we still react to stress as if we were living in a jungle, and where our main source of stress would be either lack of food or immediate danger due to a predator. And that's it. I mean, that's how our body and our brain react to stress. And so there's some short-term adaptation in the body and in the brain and in behavior, which could theoretically be advantageous if we were still facing a lion from which we have to run away, yes. Or if we were seeking for food in a jungle in the cold, or in a place, a dangerous place. And that's probably, well, obviously this behavior no longer, and I can give you some example, these behavioral changes are no longer advantageous in the current society. And that's probably, from this mismatch, partly mental health problems or behavior that are interpreted as mental health problems are created.
So in our evolution, we developed this response, which we experience as stress, and it was helpful.
Yes.
And there are times, presumably in modern life, when feeling stress can be still helpful in a similar sort of way. But there are also these times when it's very unhelpful and it's not really a useful response to have. And so
It is especially the notion that today's stress for modern society for most people are what we call chronic stress. They're not easily addressable or changeable. So if you project yourself in the jungle, you walk in the jungle, you find a predator, and you really only have 20 minutes, half an hour to either fight with the lion and kill the lion or run away from the lion.
Yeah.
So the timing of the biological response to stress is always limited to 20 minutes, half an hour, because that's the time in which you either you're lost, if you like, your fight with the stressful stimuli, or you have been able to overcome it and move on.
Okay.
And that's why it's all about the immediate reaction, and that's why the biological changes. So I'll give you an example.
Yeah.
Our cortisol levels, which is the main hormones involved in the stress response, goes up during stress. Cortisol is produced by the adrenal gland, the gland that sits on top of our kidney, and it has specific function. For example, increase glucose levels in the blood, so to give more energy to the muscles, because this is stress in a situation which you need to run away or prepare to fight. It also temporarily focus the brain on the task ahead. So it kind of it takes away input from other less important source of information, so that you can concentrate on whatever is the dangers at that moment. Your blood pressure goes up, because you need to make sure that the blood reaches all the tissue that you need, where you need the oxygen. So obviously the muscles again, but also the brain, because you need to be alert and you need to be able to identify where the danger is coming from. And so your heart beats faster to bring more oxygen around. Now, interesting is something which I've been working quite a lot, and is more a recent development in our understanding of the stress, is that the immune system also gets activated. So all the white cells, the circulating white blood cells that are there to protect us against virus or against infection, immediately get triggered, and they get ready. These cells themselves get ready to fight. And again, evolutionary is the same principle. If you're in a situation of stress, you're gonna get wounded, because you're either gonna be running in a jungle and get scratched, or you're gonna have a fight with a predator, or perhaps a fight with someone, maybe even another human that would challenge you in a physical fight as a part of a control of the territory, the mechanism that we're operating, if you like, in a more primitive society. All of this are evolutionary advantages in the short term. Now, the problem is that we don't have this kind of stressor anymore. The rare occasion where people have this kind of stressor, so in a real situation of dangers, and obviously, for example, soldier in a combat, the body may be using some of this biological mechanism to an advantage. Yeah. But it's very rare. Luckily, it's very rare. The rest of the situation for people like us is having, a job that we don't like, perhaps a relationship that is not working, or a feeling of social isolation, or having lost your country because you're an asylum seeker. Being a situation of war, which is, it's rarely a few hours. It's always weeks or months, and hence, this biological mechanism gets activated not only for minutes, but for days and weeks, and that's where they become disadvantageous.
So something that was meant to be, or evolved to be very focused, very in the moment, and so you'd get back to normal, relatively quickly if you were still alive after your encounter with the lion. Now we have lions all the time.
Yes.
Well, we have stresses all the time, and so we've got this response that we're trying to maintain, which isn't actually very useful in the long term.
No, and they also most of the sources of stress for most individuals of chronic stress are obviously social. So it could be about your employment or poverty, lack of social support, feeling victimized because of the way you integrate or you can't integrate in the society. So these are all chronic conditions.
So some of those factors, some of those things like living in poverty that you've mentioned, that those are associated with mental ill health. But I suppose what you're suggesting is that what the mechanism for that might be through this raised, stress response and the activated immune system. Tell us about your research, sort of connecting the stress and depression in particular.
So I've been interested in particular to look at how the immune system contributes to depression, and continuing in this framework, in this idea that there are aspects of your immune function that are activated in depression, which are the same mechanism that should be only operating for 1 hour, but actually get operating for weeks or months. And as part of this, the behavior, as part of this increased activity of the immune system, your behavior change. Again, because all of you will remember how you felt last time you had a bad infection. You had flu, or you had a high fever. You were feeling tired, you were grumpy, you certainly didn't want to go out and have a social life. Perhaps you also were feeling irritable and moody. And this is because what happens in a state of immune activation is that really the body communicates to the brain and saying, look, you need to stay still, save your energy, stay in a warm place, and wait until the infection the immune system wins the infection, and the infection is eradicated. And some of these mechanisms are still operating in the sense that probably some of the symptoms that people have when they're depressed are due to this increased immune activation driving the fatigue or driving the lack of the lack of desire for social interaction. So I'm particularly interested in understanding how does the immune activation leads to this behavior, and can we use this these changes in the immune system, for example, by measuring in the blood of depressed patient to understand what kind of depression this person has. How can we help this person? Are there mechanisms that we can, for example, tackle from a therapeutic point of view by interacting with the immune system?
Okay, so can you give us an example of an experiment that you've done or something that you've found that sort of brings that to life a bit?
Yes. So, for example, we've done quite a lot of studies measuring what we call immune biomarkers, so measuring molecules that are produced by white blood cells in the blood. Some of them are what we call also cytokines. So they're molecules for which immune cells communicate between them.
Yeah.
Now, so we've been measuring quite a lot of them in the blood of depressed patients. And what we've identified now quite consistently, there's a group of depressed patients, approximately 1/3 of all depressed patients, that have high level of inflammation. And they're less likely to respond to what we call, for example, conventional antidepressant. So the antidepressant that would be prescribed routinely by your GP if you were feeling depressed. So they're immediately a group of people that they may benefit from a different treatment approach. And that today, because we are not using biomarkers to, if you like, organize the treatment of a person, to personalize the treatment. Everybody gets the same antidepressant, but if or when we will be able to start using peripheral blood biomarkers, measurements, blood tests, in other words, to guide your antidepressant treatment, it will help those people to get to the treatment first, the treatment they need first.
Yeah. So do you think that the people who have those raised levels of immune system, biomarkers, those molecules that our cells use to talk to each other in a crisis, have they got a different type of depression to the people who don't have those inflammatory?
They probably have a more, if you like, biologically embedded forms of depression that comes from, most likely, from a combination of genetic predisposition and early exposure to stress early in their life. So we have quite a lot of data now showing that there are some genetic variants, so some immune gene polymorphism that brings a hyperactive immune system per se. So even in
some
normal
people
condition,
have genes
they
that
have
just mean
genes
that they're
makes
more
them
likely.
exactly. So these are people that in the short term, they may be evolutionary, they may be more protected by infection because the immune system reacts more, but also the immune system reacts more under condition of stress. So they get more depressed under condition of stress.
Okay.
So that's one pathway. And the other pathway, and potentially a combination of both, is that some individuals that have been exposed to life adversity quite early in their life, in childhood, and we actually have some data now, even exposure to adversity in utero. So
before they're born.
Before they're born, when during the pregnancy, that's enough to create a trajectory of persistent activation of the immune system, which then makes this individual more vulnerable to becoming depressed in adolescence or in adulthood when they encounter new life events.
Okay,
and so these are the group of people that, as I said, more biologically embedded, because the depression comes from either a genetic loading or exposure to life events early and continuously in life, as opposed to people that, for example, have a perfectly healthy, normal life, and then one day when in their 30s get hit by a really difficult life event.
Okay. So we're getting into some really quite, fundamental things about who we are and how we respond to things that are happening in our lives, which is fascinating. We'll come back to that. But I think at this point, perhaps you could give us a sense of, what life's like in your laboratory. I mean, how, what's a normal day like?
Well, I mean,
is it stressful?
Well, it would be, except that I love it. So.
Very good.
It's always the mismatch, between what you want to do, and I'm sure a lot of people think that my life is crazy and they would never want to switch places. It is stressful sometimes, obviously, because I'm an academic. I'm also a clinician, so I'm a consultant psychiatrist. So I have some clinical responsibility. I have quite a large research group, approximately 25 people. So it's a lot of supervision and mentoring, and finding money. Put food on the table, make sure that people can have a salary, have a bursary, have the money to do the research. And now that I'm more senior position, it's also a lot about interacting with universities, but also governmental organizations, political bodies, public engagement activities. So every day is different because I have to deal with so many difficult and different situations.
Yeah. What's the sort of balance? I mean, are there a certain number of days a week, or that you see patients, and as opposed to how much research?
It's much more research. So for clinical academics, each of us, if you like, a slightly personalized job organization, and it also depends from different stage of our life. But I see patients about once a week, so it's quite contained. Yeah. And most of the other time of the week is about having meetings with researchers, lots of writings, lots of reading, but especially lots of writings, which I enjoy.
Okay. And with with the interactions that you have with your patients and thinking about that, I mean, are you able to draw on your research in the way that you're, dealing and responding to patients' problems and concerns?
Yeah, so I do that almost in two different ways. I mean, one is at most kind of basic theoretical levels is having the patient, if you like, inspiring me with a question that are really important. So the interest which I've developed over the last few years on the in utero environment, so what happens during pregnancy and how that affect the lifelong trajectory of the offspring, of the children, really started because of my clinical activity in perinatal psychiatry, so directly offering help to women that have difficulty with mental health during pregnancy and the postpartum. So that kind of, if you like, the clinical activity has directly informed the research. But also sometimes patients contact me and this, they may be reading on the work that I do, and they may contact me and say, I've been suffering from these immune disorders, and I'm also been depressed. Do you think there's a link between these two things? Yeah.
So you can sort of maybe think about that and
Yes,
explore
gonna-
those in your lab work
and
as
we
well.
try to get the patient input also.
Okay.
And for example, at the moment we are recruiting for a clinical trial, testing whether giving an anti-inflammatory together with an antidepressant makes depressed patient better. And we immediately had quite a lot of feedback from patients that some of them wanted to participate, some of them shared the stories, even if they couldn't participate, they said, they were really encouraging, they kind of say, please go ahead, continue to do this work, is really important.
So we've heard a little bit there about the sort of interaction between your clinical work and your research, but how did you get into the field at all? What's your sort of route to this point been, Carmine?
I've always wanted to be a psychiatrist. I mean, I was reading Freud when I was in high school. I've always been fascinated by how the mind works. And it's surprising how many, actually, there's a lot of people that decide to be psychiatrists really early in their life, and then they go into medicine and become psychiatrists, because I think there's something so unique, and so also it's such a big privilege, that you really get into an emotional sphere, of that person. You may be told, you may be discussing things that nobody else know, and you may be able to help people that they don't manage to get help by anybody else, or they don't know how to seek help from anybody else. So it's a wonderful academic choice, again, clinical choice and professional choice.
Excellent, good. So we've got about 10 minutes, I think left. So let's sort of broaden it out and maybe come back to some of the things we were talking about earlier. But there's a general thing. I mean, when you were talking about reading Freud in high school, I mean, I don't think Freud was particularly interested in or aware of what the sort of molecules and cells were doing. But obviously that's a big part of your work. And actually through the 20th century, there was a sort of division that the mind and the body were kept fairly separate in the way that Western medicine certainly looked at people and treated them. But your work seems to be sort of bringing the two back together again. Is that part of a sort of wider trend that
there is certainly a wider trend to look at mental health and physical health as a single health. Even documents from the Department of Health, they advocate what they call parity between mental health and physical health, both in terms of investment, NHS availability of treatment, funding for research, and so on. And so I'm very keen always to stress to highlight that what my research does is bring the body back into depression. Is the idea that depression is not only in your mind, it's definitely not even only in your brain, but it's actually everywhere. It's in your body. The depression takes the whole individuals, and that's why you can measure things in the blood that are relevant to depression. Tell us something about how the depression is going. What can we do to help you? And I think it's part of a broader trend to bring together mental health and physical health, and also colleague from the physical health point of view. Many doctors coming from medical specialties are becoming more and more interested in multidisciplinary approach to their patient, and have always some input from psychiatrists or psychologists into oncology or rheumatology or diabetology and so on. So I think it's reciprocal.
Okay, but we still maintain those distinctions, don't we, between mental and physical health?
We do, and unfortunately, I think that also brings some of the stigma attached to mental health problems and to ill mental health. The idea that somehow, as I said, is all in the mind, and there's nothing that you can measure. And actually, there's a lot of things you can measure. The diagnosis, both the diagnosis that you can make from talking to a patient in a structured way and asking the right questions, as reliable as a diagnosis that you have in a medical disorder based on X-ray or a blood test. Okay,
as we're getting a bit short on time, perhaps we can talk. You mentioned earlier about that stress can sort of have an effect on an unborn baby, and that can sort of set you up, and your genes can obviously influence how you respond to stress and things like that. Are there broader can you tell us a bit more about the sort of what causes stress, and are there differences? Are there broad differences between, say, men and women, or as we get older, do we experience stress differently, or living in the city, one might imagine, is a lot more stressful than living in the countryside. Are those sorts of factors relevant here?
There's probably a continuity and kind of a cumulative effect of stress. So milder form of stress, being exposed to, for example, when you're in school, being exposed to a test or having to, public speaking, or perhaps going through, an important deadline, or there's some variability. Some individual will be able to cope better, and some people will feel really threatened. Some people may even enjoy it, or some people may just kind of be halfway through, just cope with it in a kind of successful way. The more you get into the more severe forms of stress, then in a way everybody's affected. Now again, a little bit more, a little bit less, but everybody's affected. And so, for example, if you think some of the most severe forms of stress, like a bereavement, a loss of a dear person, someone's dear to you, well, everybody's affected, and everybody will have at least a short period of time, weeks or months, couple of months, in which they will be upset, crying, feeling hopeless. And this is perfectly normal, and it's really important that for those individuals that are just experiencing a normal reaction to what is a horrible situation, there's not any, we don't medicalize it, we don't make it a pathological situation, we just support people and then let them move on.
Well, that can sometimes be difficult, can't it, to sort of distinguish what's a sort of normal reaction and what's not a normal reaction, and requires a bit more, maybe help from somebody. So,
and sometimes you just have as a clinician, you have to have the courage to wait. I think. And we do. I mean, it's not, many colleagues do, and we all do it. As I said, you have to be brave and tell to someone that's coming to you in tears because they've just been fired the day before and they feel completely lost, that this is normal, and let's see how things are going over the next couple of weeks, and I'll see you back in a month. And people, luckily, most people get better, adapt, use stress as a way of learning new things about themselves. The crises are also a time for growing, healing and personal growth. But, by waiting, you also find the person that a month later is actually worse than he was before. Now they've not sleeping, and now they've not been able to go out, and and maybe another couple of weeks, and they stop eating, and they start thinking life is not worth living. And that's the time when you say, okay, well, maybe this is going into a different direction, we need to help you.
So thinking about all the factors at play, is there anything we can do to sort of protect ourselves from that sort of more dangerous or unhealthy response?
Obviously, each of us has strengths, resilience, and risks. But certainly social support is the strongest protective factor that we can have. So having, a network of close friends and relatives, obviously, a personal relationship, family, this is probably one of the strongest protective factors. And that's where you should get the help that you need at the, in the aftermath of terrible events.
And first port of call.
That's always the first port of call. And I mean, there were in the past other, if you like, type of people. It could have been the priest, or a local leader, or a religious leader, which would have a similar role. But this is, for many of us now, has been lost. Not all of us, of course, but many of us has been lost.
Okay. Well, there's lots I wanted to ask you about, certain specific situations, like sort of post-referendum stress, but maybe somebody can ask a question about that, because as we come to the end. Tell us, make a pitch for us, as to why is your research important? Why should we all be interested in this? What's it going to, do for us?
I think you in a way you said it. It kind of touches the key questions about who we are, and why some of us react one way, some of us react another way. Why some of us need help before, some of us need help later. It's really about try to understand when suffering brings something good, and when suffering only unfortunately brings something bad that needs to be eliminated. And is finding the right compromise between giving time for a person to, as I said, heal and growth, but also intervene if needed.
And how do you see your research and perhaps the field more broadly developing? I mean, what's coming next? What are you sort of hoping to see in the next few years?
I think we're really on the verge of a revolution in psychiatry, because we can really move into personalized medicine within psychiatry, which is something which has not been done yet. Now, in oncology,
yes.
the treatment, there's not such a thing as the treatment for colon cancer. There are all different combination of different medication which are based on the individual patient genetic profile, and so something like this, the idea that you can measure things in the blood of the depressed patient, like we're doing, and saying, look, your blood tests telling us that you will be perfectly fine on a standard antidepressant, the one that every GP prescribed, just go on it, you'll be fine. Yeah. Or saying, actually, the blood test says you really have no chance to respond to this standard antidepressant. Perhaps you need a combination of antidepressant, perhaps an antidepressant with an anti-inflammatory. Let's not waste time just trying 2 or 3 drugs. Let's drug straight in something that will help you in particular. And the interesting thing that is personalized medicine is not only about blood tests. We're now doing personalized psychiatry also for psychological therapies. So probably many people in the audience know the basic psychological treatment like cognitive behavioral therapy, which are quite, at the moment, they are one-size-fits-all approach. It's almost like a protocol for everybody. But more and more there's research going on, including at the institute where I work, at the Institute of Psychiatry, that says, well, actually, some individuals have very specific psychological mechanism. They, for example, interpret events in a threatening way, even when the events are neutral, or they're excessively perfectionist. And these are the key mechanisms that need to be tackled by psychological treatment that tackles that mechanism. So it's across the whole ability to help mental health.
Well, great. Well, thank you very much for sharing that vision with us and for describing your research to us. And on that note, I'd like us all to thank our speaker, Professor Carmine Pariante, and say goodbye to our podcast audience, and thanks for listening. Yes, great. So we will have some questions. We have a roving microphone so that we can all hear the question clearly from you. So if you can put your hand up and I will call you, and we'll get a microphone. This gentleman here is first.
Thanks for a fascinating talk.
Thank you.
So you mentioned that stress can lead to a boosting of the immune system, which makes perfect sense. You're facing possible danger, so your immune system gets ready. But I'm sure I've read people saying, blaming stress for depressing the immune system, and that if you're stressed, you're more likely to get ill. Can you explain the contradiction?
Yes, it's an interesting point. That mostly over the 80s and the 90s, there was this idea that depression would depress the immune, would lead to impairment of the immune system. And for example, this notion that if you get stressed or if you're depressed, you're more likely to develop cancer or disorders that would mean that your immune system is not working. Actually, the most recent evidence and the largest studies never really found strong evidence for that. It is possible that because some component of the immune system are activated, other component gets deactivated in a way to compensate. But from a clinical point of view, there's definitely not evidence of immune depression, immune suppression during depression. There's not
the immune system is such a complicated thing anyway, with things that are sort of you can have a raised activation of something that is switching off all sorts of other things. And
yes.
You can, so
and probably some of the results that indicated that the idea was coming from other blood tests, if you like, which were registering other cells. But overall, there's no evidence of an immune suppression.
There's a question down here at the front. And then I'll come.
Yeah, hi, thank you. I'm going to try and put this briefly, not easy. So 2 things from a personal perspective of people I know close. One, the link between things like eye is it IBS? Have I got the right initials? Digestive stuff, social anxiety, depression. I would suggest then a circle and a circle and a circle. And also the link between rheumatoid arthritis, and yes, those links. That sounds to what you've said sounds to make perfect sense. So my initial reaction is I want to go and tell those people, just go and see your local GP and get a nice biomarker blood test done, and we'll sort out, because one of these people is on antidepressants, one is on serious rheumatoid arthritis medication. So you sort of think, there could be another way of looking at this, but is that open to ordinary Joe public?
What do you
think? So it is a complicated question. No, but you're perfectly right. One question is about the mechanism. So, for example, try to understand why some people, especially under a situation of stress or anxiety, experience more somatic symptoms in the stomach, irritable bowel syndromes. Why some people, in response to stress, for example, experience fatigue, and why some people the fatigue becomes chronic. And it may well be that the immune mechanism, so especially this increased immune activity early in a situation of stress, drives some of these changes. Now, the fact that the immune system is involved, it doesn't mean that then we can easily just switch it off until we know exactly what is the molecule involved and what is the best, if there is a drug that can be used. Now, having said that, there are currently, for example, trials with anti-inflammatories for chronic fatigue syndrome or ME, for irritable bowel syndrome. So there's definitely an interest, and there will be more data, more studies looking at whether this phenomena also respond well by treating the inflammation. Now, the other things you need to remember is that sometimes depression is also secondary to the impairment in life that derives from some of these syndromes. So, there's also an adjustment and mental health difficulties that comes from the fact of having a chronic condition like this. And so, they may still need psychiatric care from that point of view, at least for some aspect of it and some time in their life.
I think we'll take the question at the back and then...
Hi. My question really relates to previous two. I was just wondering how you've been able to determine cause and effect, really. That is the immune system driving the psychological state and not the depression that's driving the immune system?
So there's probably a little bit of both. So the best way to interpret the kind of immune activation during depression is the part of it is driven by, if you like, a trait, and part of it is driven by the state of being depressed. But if you look at some the data, for example, that I mentioned before, that some individuals have a genetic predisposition that even when they're not depressed, they have a high immune activation, but they are more likely to become depressed and to become even more immune activated when they're exposed to stress. Similarly, some individuals have because of a history of exposure to early life trauma in childhood, they have a persistently elevated or activated immune system even when they're not depressed. But if they're exposed to life events, their immune system gets more activated and they become more depressed. There are longitudinal studies showing that, probably if we take the blood of everybody in this room, there probably be 10% that which will have higher level of immune biomarker just by normal distribution, and this 10% is more at risk of becoming depressed in the next 5 years, even if they're currently there's no difference in their mood. So I think there's enough evidence showing that part of it is driven in a causal way.
And just to pick up on the earlier points as well, that 10% who are at high risk of depression, are they at high risk for other autoimmune diseases and things like that? Are you able to say that?
There's not, again, it's not very clear if there is a link. We know, for example, that early life exposure to trauma increases the risk of a range of other disorders, also diabetes and coronary heart disease. And some of it is through change in lifestyle. So, for example, this individual may be, because of obviously they bring, a load of difficulties and more difficulties in their life. They may be smoking more, or they may be have a less healthy eating habits. So some of the medical comorbidity comes from the lifestyle, but there's also a possibility there's the immune system driving diabetes and coronary heart disease. And we definitely know that depression makes diabetes and coronary heart disease worse. With the inflammatory disorder, rheumatoid arthritis is a little bit less clear, but with probably because these are disorders where the immune system attacks very specific joints or very specific tissues. But the situation where the immune system is more attacks, if you like, it's diffused across all the body, like diabetes and coronary heart disease is much more, the effect of depression is much more profound.
Thank you. There's a question here on the corner, and then we'll have two from the side there.
Thank you. As a scientist, you determined that there's an immune response. As a clinician, could you expand upon your treatment regime that you would utilize for a patient that you think can benefit from your knowledge?
So at the moment, we're still talking within kind of experimental clinical trial scenario. So I don't, in my clinical practice, I don't use any, for example, I don't use any anti-inflammatory in the treatment of depression because simply we don't have enough patient treated in a controlled way to determine the risk benefit. So as I said, I'm doing a clinical trial, for example, where we are offering an anti-inflammatory called minocycline. It's an antibiotic which is quite powerful anti-inflammatory activity. It is within an experimental settings, with where patients are obviously offered the choice of participating to the trial. The only things I recommend to patients with, if you like, my immune hat is fish oil supplement, which we know that tend to have an immunosuppressive effect, and they have some data in depression showing they're beneficial. So there are things we can advocate and we can advise that the risk benefit is very clear and the benefit overcome every risk. But for example, I don't say to patients, in fact, I always add, when I discuss things like this, I always say to everybody, please, if you're depressed, if you're taking antidepressant, don't rush and buy ibuprofen or aspirin just to take it, because we don't know what's the best combination regime, we don't know the doses, we don't know if there are side effects. So it's not the time yet to change clinical practice. The work I'm doing is about changing the clinical practice in 5 years' time.
But it is fascinating, though, isn't it? Because there are studies on, that taking a mini aspirin can help reduce your risk of cancer or certain types of cancer. So inflammation seems to be, everywhere, which of course it is, but having a really, fundamental role in a lot of diseases. I know we've got a couple of questions on the side, so we'll take the lady in the middle. If you can have the microphone there. Thanks.
I wondered whether in your research you'd found any link between atopic individuals, so people with like eczema and asthma, and depression and stress in later life.
So again, there's largely anecdotal evidence rather than real epidemiological evidence. It's interesting that there is some notion that allergen and atopic reactions, there seems to be on the increase in the last, kind of 20, 30 years, and some other scientists in the field related to me. I mean, I don't do research specific in this area, but they, for example, have hypothesized that the fact that we live in a much cleaner environment, we are not, especially as kids, we don't interact anymore with the germs and the parasites that were more part of the general life in a countryside, for example, or the life in 100 years ago. That this, in a way, makes the immune system overreacting to other bits and pieces in the body because the cells don't react to what they're supposed to be reacting. So there's some interesting area of research, but there's not a clear link with depression, at least not has been demonstrated yet.
Okay. And your neighbour just there?
Hi, just touching on this gentleman's question about anti-inflammatories and antidepressants. So I just wanted to kind of get your opinion on antidepressants in terms of if you think they're overprescribed, and like from a more holistic point of view as well, the anti-inflammatory medication, that all sounds fairly new, and also connecting the mind and the body in depression, and so your ideas on like movement therapy and this type of thing also. Thank you.
You're touching on a really important point. So We know that there has been an increased trend for prescription of antidepressant over the last 20 years, everywhere in the Western world, UK, Europe, America, and so on. Now, I don't know if it is overprescription. It's definitely a lot is about people seeking help more, being able to go to the doctors and ask for help because of the reduced stigma, so that's a positive consequence, and perhaps also improved ability of doctors to identify and recognize depression. And we also know that there is certainly a group of people that are depressed and they wouldn't require or they would definitely benefit from antidepressant, they still don't get antidepressant because they don't seek help or they're not recognized. There is a risk, and I recognize we were discussing before, that there's a risk that normal suffering as in a reaction to difficult life circumstances gets medicalized. But I want to say, as a clinician, that as a psychiatrist, there's a risk that is coming, if you like, from both directions. There's pressure from, there's also pressure from people. There's pressure from the patient to sometimes to receive a quick fix for the suffering, and it's difficult sometimes. And sometimes I have to argue with the patient, say, look, I know you're suffering, but it's perfectly understandable for what is going through in your life. Can we please wait? I don't want to prescribe an antidepressant now. So, when we talk about overprescribing, we always think about, the doctor, they don't want to spend time with the patient, just give them a prescription because they want to get rid of him or her. But it's not like that. It's also about the pressure from the patient, from the people that actually would like to just to switch it off. And sometimes it's difficult to say, no, you can't switch it off. So it's complex, it's complicated. Now, in terms of anti-inflammatory, as I said, I think I truly believe they're actually a really powerful antidepressant strategies for the future, but only for the people who needs them. So perhaps people that have high level of inflammation. But it's a model at the moment. It's an experimental model. We need larger clinical trials. That's why, as I said, I don't prescribe anti-inflammatory to patients. At the moment, I don't advocate people to do it themselves. We know that a lot of treatment that are, as I said, the interface between the body and the mind, relaxation, mindfulness, physical exercise, they all have an effect on the immune system. Probably of this one, physical exercise is the strongest natural anti-inflammatory, together with fish oil supplement that obviously is natural because it's a nutrition supplement rather than a pharmacological intervention. So there are things you can do absolutely that tackle the same mechanism in a non-pharmacological way. And it may be that people that are, if you like, halfway through, so they have perhaps a mild depression response to a life event, they're struggling a little bit, but they don't really require, they don't want an antidepressant. These are the people that may be benefiting from relaxation, physical exercise, a better nutritional supplement. Once you get into the moderate to severe end of depression, the people that don't leave their home, they've not been able to go back to work, they're not eating, they're not drinking, they're thinking about taking their own life, you really need to think about an antidepressant. You just don't have the time, the luxury to wait, because, if someone is unemployed and then the family life is ruined because of the depression, you just create a spiral of circumstances that you need to break.
Great. Lots of questions now. Let's have this lady here, and then we'll come to the back.
Thank you. I was wondering if you'd make a distinction between stress and trauma, because you talked about early life adverse experiences and even thinking about developmental trauma versus complex trauma or incident-specific acute trauma. And I'm wondering about that as well, connected a bit to the last question, because in contemporary trauma research around PTSD, they're finding a lot that somatic work is having fantastic results in collaboration with talk therapy and medication as well. But even something as simple as some kind of rhythmic exercise can help break a pattern. So I'm just curious what your thoughts on that.
Yeah, I mean, a lot is terminology, is semantic. Usually trauma seems to have a kind of more severe connotation. But you could use trauma for an acute event, a car crash, which has just happened once. But you can use trauma also for, exposure to maltreatment or bullying or physical abuse over months or years or the whole childhood. So I think it's probably used in interchangeable or just with a different nuance of severity. It's interesting. We still don't know why some people develop a predominantly PTSD kind of reaction. So a post-traumatic stress disorder is a reaction to traumatic events where the arousal is predominant. So the feeling of anxiety, the feeling of feeling under threats, the feeling often having intrusive memories or experience almost of reliving the traumatic experience. And some people do develop that, and other people instead develop a more more depressive, more inward directed kind of a reaction. We still really don't know why, and whether it's part of their trajectory, what happened to the life before, if, the way the life was before perhaps shaped the way they react to the trauma. And obviously resilience is part of one of the outcomes. So some people actually just go through a phase of difficulty and then return to normal.
So we might have time for just one or two more questions. I know there are a couple of hands at the back. We'll have the lady here first and then the gentleman at the back, possibly the last one.
Hi. Can you tell me, if one loses an adrenal gland, presumably you then produce less adrenaline. A, does the other one make up for it? And B, does it have any good implications? Presumably it's not so good if you're in the jungle with a lion, but in normal everyday situations, is it beneficial?
That's a great question.
It's a great question. I actually don't think there is, clear clinical studies looking at that. Usually the other gland can compensate a lot because it gets, it literally gets bigger and produce more adrenaline and produce more cortisol. So you only have a condition where you need, for example, to take substitute hormones if you lose both glands. And it happens usually as part of autoimmune reaction or other condition like this. So it probably, with one gland, I think that overall there's nothing positive, if you like. There's probably nothing negative unless you're in a very severe situation. So if you have to undergo surgery, where normally there's a massive release of cortisol to protect the body to cope with surgery, then a situation like this, a doctor would give you more cortisol or more adrenaline to make sure that you have enough. But a normal condition, it probably wouldn't have any effect.
Okay, let's squeeze in one last question from the gentleman at the back there.
I've come across research that suggests that men and women may respond to stress differently because of, if you like, the way different hormones are triggered. Has your research suggested anything along these lines?
It's interesting. So, obviously there are some differences in the way estrogen and progesterone and androgens kind of regulate behavior. But in terms of stress response, it's not as clear and as different as you would anticipate. So even for disorders which are more, if you like, typical of one gender or the other, so postnatal depression, the link with sex hormone are not so clear. So there's a lot of emphasis now on the fact that perhaps the difference between men and women in terms of their risk of mental health difficulties, for example, are much more about social and cultural and expression of distress. So in fact, the current epidemiological data shows an increase in the prevalence of depression in males. But we don't know whether it's simply that men are now learning to express distress in an emotional and way, as opposed to get drunk and get irritated. So it's part of this. It is about culture, actually, the way that the two genders have been expressing their distress in different ways, and how this actually is becoming more unified currently in the Western world, obviously.
Well, I think it sort of goes to the heart of what we've been talking about, hasn't it? That you can learn so much by understanding the sort of the biology, the cells and the hormones that are involved. But obviously, whatever hypotheses you come up with, they've got to be reflected in the real world if they're going to be of use to people. So I think we are just about out of time, so thank you very much for all your fantastic questions today. Do remember that you can listen to previous packed lunches on the website through the podcast. This one will be up in a few weeks if you want to hear it all over again. We'll be taking a break from our packed lunches in August, so if you do want to recreate one at home, there's your opportunity. But look out for the next one, which will be in September. And that just leaves me to say a very warm thank you for coming along. Thank you to all of you, and please join with me in saying thank you to Carmine Pariante.
Thank you for listening to our podcast. I hope you enjoyed it. If you're interested in other events and exhibitions at Wellcome Collection, please do visit us online at welcomecollection.org.